Reduction of overcorrection of ptosis. The physician administers local anesthetic and the patient's face and eyelid are draped and prepped for surgery. With an incision usually at the previous incision line, the physician attempts to reduce a previous overcorrection of ptosis. The levator aponeurosis is cut free of disinserted from its attachment to the levator aponeurosis, and the incision is repaired with sutures. Correction of lid retraction. The physician administers local anesthetic and the patient's face and eyelid are draped and prepped for surgery. The physician outlines the incision line, usually in the crease of the upper lid. The distal portion of the tendon responsible for elevating the lid, levator aponeurosis, is isolated from its attachment to the tarsal plate. The levator aponeurosis is allowed to retract itself posteriorly or autogenous graft materials are inserted between the levator aponeurosis and the tarsal plate. The patient is generally placed in a sitting position and the amount of the retraction of the levator aponeurosis is judged by the position of the eyelid while the patient is sitting on the table. Alternatively, the eyelid margin may be placed approximately 2 mm below the limbus. When the lid is positioned satisfactorily, it is affixed. The incision is closed with sutures. Correction of lagophthalmos, with implantation of upper eyelid lid load, e.g., gold weight. Lagophthalmos is a condition in which the upper eyelid is not providing complete closure to the eye, causing dryness and other complications. This code reports lagophthalmos correction using the insertion of a gold weight or other lid load into the upper eyelid for gravity-assisted closure. The surgical field is prepared around the eye and a traction suture is placed into the lid margin. An incision is made in the lid crease and dissection is carried out on the upper lid structures to expose the anterior surface of the tarsus. The weight to be used has been predetermined, it is centered over the exposed upper tarsal surface and sutured into place. After irrigation, the orbicularis oculi muscle must be closed over the inserted weight and the crease in the eyelid is restored through suturing. Antibiotics are applied and the eye is patched. A traction suture is placed through the lid margin. A lid crease incision is made. Dissection of lid structures is performed demonstrating the orbital septum and the anterior surface of the tarsus. The previously determined gold weight is centered over the bare superior tarsal surface and then sutured into position. The wound is irrigated with antibiotic solution. Orbicularis oculi muscle is closed over the implant. The traction suture is removed. Skin is closed over the orbicularis oculi muscle, including several passes through the superior border of the tarsus to restore the superior eyelid crease. Antibiotic ointment is placed over the wound and a double eye pad is applied. Nerve repair, with synthetic conduit or vein allograft, e.g., nerve tube, each nerve. Nerve repair, with autogenous vein graft, includes harvest of vein graft, each nerve. The physician makes an incision over the damaged nerve and dissects tissues to locate the nerve. The damaged area of the nerve is resected and removed. Innervation is restored by building a bridge to each end of the resected nerve and suturing the proximal and distal ends of the bridge into place around each severed nerve end. This technique is usually limited to nerve gaps of 3 cm or less. The bridge is usually 1 cm longer than the defect so that it covers the distal and proximal ends of the resected nerve. The bridge is composed of a bioabsorbable, corrugated synthetic conduit of polyglycolic acid. Once the bridge is sutured into place, the artificial nerve conduit is infused with a solution of heparin and saline to prevent clot formation. The operative wound is repaired in layers. Over time, the nerve conduit is restored and the tube is resorbed by surrounding tissue.